Hello everyone, let's start from where we left off. Metabolic abnormality during vomiting. We all know, let me just make it simplified in two, three lines because you don't need the details. They will not ask you the details. See, this is our stomach. When we vomit or there's an NG suction, what do we lose? We lose sodium. We lose HCl. That means HCl as H plus and Cl minus. So what? Simple and easy. Hyponatremia, hypochloremia, and of course we're losing acid, so we will have alkalosis. So this will be metabolic alkalosis. Metabolic alkalosis. And with hyponatremia and hypochloremia. Sodium low, chloride low. So hyponatremic, hypochloremic, metabolic acidosis. Physiological abnormality, neurogenic shock. Simple and easy. What happens in neurogenic shock? Guys, neurogenic shock happens when we have a high cervical spine injury. Why? Because cervical spine injury, high cervical spine injury, we have sympathetic chain along our vertebral column. What happens when we have a high spinal injury? This sympathetic chain breaks. Sympathetic chain breaks. To make it simple and easy, so what happens due to sympathetic chain break? We lose our sympathetic activity. So hypothalamus stimulates sympathetic chain, and sympathetic chain release acetylcholine, preganglionic fibers, preganglionic sympathetic fibers release acetylcholine. Acetylcholine goes to adrenal medulla. Adrenal medulla secretes epinephrine and norepinephrine. Now, epinephrine stimulates alpha 1, alpha 2, beta 1, beta 2. Alpha 1 is a powerful vasoconstrictor, but norepinephrine works more on alpha 1. Epinephrine works less on others. Now, we all know that alpha 1 causes vasoconstriction. Vasoconstriction increases total peripheral resistance. And from total peripheral resistance, we get increased venous return. From increased venous return, we get increased end diastolic volume. The more blood comes in your heart, the more heart gets dilated, and dilation of the heart is diastole. What happens? Dilation of the heart is diastole. So at full diastole, we get the volume. If more blood comes, let's say 6 liter blood comes, so volume would be 6 liter. So our end diastolic volume would be 6 liter. Now, the more heart will stretch, heart have gates. The more heart will stretch, the gates will open wider. And who enters through these gates? Calcium inside heart muscle. So more stretch, more calcium up to a certain limit. And more calcium, more force of contraction, because heart muscle contraction depends on calcium. So what do we get? We get increased venous return, we get increased end diastolic volume, so we get increased preload, we get increased cardiac output, and of course due to increased end diastolic volume we get increased force of contraction. So increased BP. So alpha 1 will increase BP. What about others? Alpha 2. Alpha 2 causes dilatation of the pupil. Not so important, leave it. Beta 1 and beta 2. Remember, we have one heart and two lungs. Simple. So beta 1 will work on heart. It will increase heart rate. So it will increase cardiac output. So it will again increase BP. It will cause bronchodilation. Bronchodilation. So increase oxygenation. Increase airway diameter. So that's why we give it during anaphylaxis. And of course, it also causes skeletal muscle blood vessel dilatation. Why? Because we know sympathetic system is fight or flight. Now for fighting, we need blood supply in our biceps, right? And for flight, to take a flight, we need to jump, right? So we need blood supply in our legs. Simple as that. So that's how it will increase blood supply to our skeletal muscle and it has a risk of decreasing the BP. But see, there are two actions to increase the BP and one action to decrease the BP. So increasing BP action will be more. So this is the job of our sympathetic chain. Now when we have a neurogenic shock, that is, this chain is broken. So what happens? Sympathetic signal goes, but it does not reach adrenal medulla. That means we have no nor AP. So alpha 1 gone. So we will have dilatation of vessel, massive vasodilatation, total tone of vessel lost, massive vasodilatation. So decreased total peripheral resistance. So decreased systemic vascular resistance. Same thing, when systemic vascular resistance is decreased, our venous return will decrease. When venous return, heart getting less blood, let's say instead of 5 liter it's getting 2 liter, so heart getting less blood. So heart, to make it more simple, if heart gets less blood, it will give less blood. Simple. Now for medical term, because they give you an exam, so its end diastolic volume will be low, its preload will be low, its cardiac output will be low. When preload is low and end diastolic volume is low, that means heart is stretching less calcium is going in, so less force of contraction. Simple and easy, less force of contraction. So in both way, less BP. So that describes hypotension. Hypotension. Again, we have no epinephrine 2. Let's forget alpha 1 for now. Alpha 2, forget it. Let's talk about beta 1. So beta 1 is increased heart rate. So beta 1 increases heart rate. So our heart rate will be low. Heart rate will be low. No beta 1 activity. Again, when heart rate will be low, our cardiac output is also low, our systemic vascular resistance is also low, our BP will just fall. Baby, I am down. Gone case. Okay, so in case of neurogenic shock, this is the thing, that everything goes low. Everything is low. And this describes the beautiful thing. that every shock have tachycardia. Of course, not cardiogenic shock, tachycardia, like our hypovolemic shock, septic shock. Main differentiating point from neurogenic shock is heart rate low. So a person is in ICU and you get a question that he is hypotension. How do you know without knowing anything that that person is having hypovolemic shock or septic shock? Hypovolemic shock, of course, if he has an RTA, you can have that, but you don't know that. You want to differentiate between septic shock and neurogenic shock. Just look at heart rate. Just look at heart rate. Heart rate low. Heart rate low, it's neurogenic shock. Heart rate low, it's neurogenic shock. Simple. So low systemic vascular resistance, low heart rate. Very simple and important piece of information, guys. Very important piece of information. Like, it will help all your life. All your life. Like, then 14-year-old girl presented with peri-umbilical pain. 14-year-old girl with peri-umbilical pain, vomiting, fever. Peri-umbilical pain. Anytime you have a peri-umbilical pain, remember our this area of gut is supplied by T10 dermatome. I mean, is connected with T10 dermatome. It's supplied by T10. It's connected with T10 dermatome, and T10 is around umbilica. So anytime we have a pathology in our appendix or in our tubes, in case of a female, first presentation will be periumbilical pain. Okay. Now this area is supplied by thoracic segment 10, T10, T10 segment. Okay, by thoracic splanchnic nerve, splanchnic nerve, and this umbilical area is T10. That's why we get pain at this area. We have a beautiful picture in our abdomen. Just last picture, just watch that picture. Let me show you. Okay, no, I don't think I have that much time. Still, let me show you one time. Paper 1, anatomy, just our abdomen PDF. The last picture. See this one, see this one. This is our thoracic segment 10, supplied by thoracic segment 10. So this area, pain will be referred to peri-umbilical region. Embryological origin of stapedias, nothing to explain, memorize. Very important, very important. Competitive antagonism of morphine, naloxone. I have told you several times, a lot of times. I use these words again and again, so you remember it. Surgeon advised to skip the following drug of a 56-year-old diabetic patient before surgery. It's just an information that empagliflozin should be skipped. Empagliflozin should be skipped. Okay. Biopsy finding of a non-caseating granuloma. C. A non-caseating granuloma. In a non-caseating granuloma, what happens in a granuloma? I have told you in class, explained that in case of, let's say, an inflammation started, and where within minutes neutrophil will come, to this place. Let's write N. This is a bacteria. Okay, let's say this is a bacteria or some inflammation. Neutrophil will come within minutes to hours, like 2-3 hours. 2-3 hours, neutrophil will come. Then neutrophil will call macrophage. Simple, within 24 hour. 24 hour. Now, what are the other players in this area? Liver has produced complements. Complements are short proteins. Complements will come here too. Complements. What does complements do? three-way. Complements binds to bacteria or pathogen on one hand, or inflammatory things on one hand, and binds antibody. FC portion of antibody on other hand kills with antibody, or kills with macrophage, or lyse membrane of that bacteria with membrane at a complex C5B678 9. Okay, so now when these things cannot finish the job, what's next? Neutrophil came, macrophage came, but they could not do it. They could not finish the job. So macrophage will call meeting with other macrophages, and 2 3 macrophages will become a big macrophage that is called epithelioid cell. Epithelioid cell, a big one, epithelioid cell is 2 3 macrophage becomes an epithelioid cell. Now days goes by and years goes by and inflammation continues, and of course we will have lymphocytes from plasma cell, and here of course these epithelioid cell will join together too, and they will make giant cell e e. So this is a granuloma. So in a granuloma we have, of course we don't have neutrophil anymore, because the neutrophil, we have some neutrophil. It's a battlefield here, and we have here macrophage, we have here lymphocyte, as after a long time we have antibodies formed, and lymphocytes here, and epithelioid cell, and giant cell, all of these things. And according to giant cell criteria, we know what's that organism that's causing this. Okay, so we have it all. Now in a non-caseating granuloma we will found all these things, but epithelioid will be found most. So this should be the best answer, lymphocyte. It's just, if they say chronic inflammation, in that case macrophage and lymphocyte would be best answer. So like it has not formed granuloma, before forming granuloma we have only these three: neutrophil, macrophage, lymphocyte. Lymphocyte is predominant there. So after a long time epithelioid cell and giant cell appears, that time it has become a granuloma. So epithelioid cell will be the biopsy finding criteria, characteristic finding for non-caseating granuloma in case of MRCS part A. You don't need to know more details, just remember what I said. Just remember what I said, and you will pass this exam, because whatever I am telling to make you pass this exam, make you pass this exam. 52 people passed in last diet. You talk to every single person, and they will tell you that how much contribution is from backbenchers for their success. Okay, there are people who passes without any assistance, even without any books. They don't even have to study. Okay, there are a lot of people like that, but there are people who would have done it, but it would be very hard for them, very hard for them. So you will understand when you go to give the exam. Which of the following is mostly related to the passage of chyme of intestine? Passage of chyme, of course it's talking about motility, so motilin would be the best option here. Just remember this thing, memorize it, it's important, memorize it. Memorize this question. 1 month following gastrojejunostomy, 46-year-old man experiencing severe abdominal. 1 month following gastrojejunostomy. Severe abdominal pain, vomiting, nausea after 2 hours of taking his meal. What's the most common metabolic abnormality patient is experiencing? Guys, in case of a gastrojejunostomy, we mostly patients experience hyponatremia. Okay. Cerebral blood flow, we know it already explained. 35-year-old male present with severe respiratory distress, and he was positioned to prone. What's the mechanism of improving respiratory difficulties? Improved ventilation, perfusion, mismatch. So we know in prone position what happens. In supine position, lung base is mostly perfused. In prone position, so see this area is downwards, right? In prone position, a lot more area is downwards. So increase surface area. A lot of area where previously blood goes less, like apex and other areas, now all the places takes more blood, more blood. So perfusion improves. Perfusion improves. Simple. Gunshot injury to left fifth intercostal space in mid clavicular line. Which part of heart is most commonly injured? Simple. This is a beautiful question, and this question you would love it. Left ventricle, you know it. Fracture of fourth rib, right side following hit by motorbike. Which part of thorax? Most commonly injured. Very simple. Fourth rib, middle lobe of lung. Middle lobe of lung. Anytime they mention fourth rib or fourth intercostal space in MRCS part A, always remember they are talking about middle lobe of lung. They will not give any question about fourth intercostal space that will not indicate middle lobe of lung or something related to middle lobe of lung. So just keep it in your mind. Which has more resistance in respiratory system? Karina, of course, I told you. Positive predictive value increase. Memorize the, we will you will have it in our arrows, our arrows, and it will come with the same stem with the same answer. So just memorize it. Metabolic disorder scenario regarding ACTH. So you know what happens during ACTH, don't worry about it. Mostly they give Addisonian crisis. Addisonian crisis, nothing other than that. What do you give? 100 milligram IV hydrocortisone. ACTH, they will give you this question only. This question, trust me, they will give you this question only. Con syndrome, increase aldosterone. We all know. What did I tell you during class? Con men take salary. Previously, when we did not have paper money, salt was used. So, and that's why it's called salary. Now, what happens? What is a con? Con means churi in Bangla, to steal. So, what does conman do? Conman steals salary. So what happens? It will take salt inside your body. Salt accumulation. Corn will accumulate salt. Corn will accumulate salt. So increased aldosterone is the reason for corn syndrome. Increased aldosterone, because aldosterone increase sodium absorption from our distal convoluted tubular cells in exchange of a hydrogen or potassium, either hydrogen or potassium. 36-year-old woman with severe abdominal pain, vomiting with bloody diarrhea. CBC shows microangiopathic anemia. LDH level, she is diagnosed with hemolytic uremic syndrome. So see, no matter how complicated picture they give, the question will always follow what I say. They are just asking the organism of hemolytic uremic syndrome, that is Escherichia coli. A group of women, you know it, already described. Acute suppurative otitis media. Patient is having pain in cheek. Which muscle is responsible? Cheek buccinator. And what's the supply of face? Of course, you know, trigeminal nerve. Sensory supply, trigeminal nerve. And trigeminal neuralgia will affect which of the following muscle? Masseter. Okay. Just memorize it because you will have pain during chewing. Pain during chewing. Pain during chewing. So trigeminal neuralgia will affect this nerve. 34-year-old bodybuilder cannot raise his left arm due to engorged vein. What is this? This is Paget's Corner syndrome. You might get confused with thoracic inlet syndrome, but remember, there is nothing. We didn't teach you thoracic inlet syndrome. We taught you thoracic outlet syndrome. Okay. The thing that comes to your mind is thoracic outlet syndrome, and Paget's Corner disease is one kind of thoracic outlet syndrome. Okay, thoracic outlet syndrome. See, we have it in our flashcards. We will upload it in our flashcards. Okay, you don't need to know nothing much. Just remember, they will give you some clues. Anytime they mention weightlifting or swimming with upper extremity engorged vein. It's Paget's Corner disease. Engorged vein. Paget's Corner disease. Floor of lumbar hernia formed by fascia transversalis. Anatomical anatomical point to remember. Like anatomically related point to remember. Okay. Following CABG, patient having sternal dehiscence, wound debridement and muscle repair has undergone. Now sternal blood supply depends on. Remember, when muscle repair has undergone, when muscle repair has undergone, the blood supply of sternum the flap depends on the flap. Let's say we took the flap from pectoralis major, which is the commonest. If we took the flap from pectoralis major, supply will depend on thoracoacromial artery or lateral thoracic artery. Thoracoacromial artery or lateral thoracic artery. If latissimal dorsiflap was used for reconstruction of for muscle reconstruction, okay, for reconstruction, as that person is having sternal dehiscence due to lack of blood supply, of course, because in CABG what do? We harvest internal thoracic artery. We take internal thoracic artery, we cut it out. Internal thoracic artery stays at the side of sternum and gives blood supply to sternum. Now we cut internal thoracic artery, and we use that to do the bypass grafting. That's the artery of choice for bypass. Artery of choice. Now who will give blood supply to the sternum? Additional blood supply from intercostal arteries and other arteries. But if sternal dehiscence occurs, we need to repair it with a muscle. So if we use pectoralis major, the blood supply will come from thoracoacromial artery. If we take latissimus dorsi, the blood supply will come from thoracodorsal artery. The blood supply will come from thoracodorsal artery if we take or use latissimus dorsi muscle to repair the sternal dehiscence. Or if rectus flap is used, superior epigastric artery will give blood supply to the sternum. Okay, not internal memory artery. Internal memory artery is not there anymore after CABG. That's the point of mentioning CABG. After CABG, we don't have internal memory artery or internal thoracic artery near sternum. So we don't know what was the question. If the question was now sternum blood supply does not depend on if that was the question, if they ask now on which artery sternum blood supply does not depend on, answer will be internal thoracic artery. And if the question was now sternum blood supply depends on, remember about the flap, if they mentioned which muscle, you select according to that artery. Okay, just three muscle with three arteries, only these three. So, or and one of the arteries are here, that is thoracodorsal artery. If they don't mention any muscle, just remember the names of these arteries. Just remember the names of these arteries. They will not give superior epigastric because it's less common. They will give either thoracoacromial or lateral thoracic artery or thoracodorsal artery. Okay, so sternum blood supply depends on thoracodorsal artery if latissimus dorsi flap is used, or thoracoacromial artery. And sternum blood supply does not depend on internal thoracic artery. Hydrocortisone is superior to dexamethasone due to mineralocorticoid action. Memorize it. If this question comes, it will come with the same stem with the same answer. Following severe crash injury, a 35-year-old man undergoes bilateral lower limb amputation, and tourniquet is applied. BP 110 by 70. What is the immediate next step? This is this is a scenario of hypovolemic shock. What do you give? Crystalloid. Correct the shock first. Correct the shock first. Okay. Depolarizing anesthetic. We all know succinylmethonium. Explained. 66 explained. Epistaxis from little area. Positive explained. Structure passes through jugular foramen. Not anymore. Then paper 2. Before starting paper 2, let's have a break of 5 minutes. Okay, just maintenance fluid calculation. Holiday Segar formula 4 to 1 rule. 15-year-old male presents with unilaterally enlarged testes. Labs are unremarkable. Orchidopexy. Anytime orchidopexy is mentioned, just forget everything. Forget about the age too. Because if the mean age is 40, but still, first provisional diagnosis would be seminoma. Anytime orchidopexy is mentioned, orchidopexy is related with seminoma, no matter what the age is. 49-year-old female has nephrostomy due to infected hydronephrosis. What is the best investigation to follow up? Hydronephrosis mentioned, go for antegrade urethrogram. Go for antegrade urethrogram. Retrograde due to urethral injury. Here we have given beautiful one line as explanation. Just remember this. Remember these, and these will be enough for your MRCS part A. 7-year-old child has pain. You don't need to study a lot. You just need to study same thing again and again, so you don't forget the important things. You just need to know important things. You don't have to be jack of all trades. You cannot do everything. You cannot know everything. You can't. Like we have a practice in Bangladesh that surgeons give treatments of COVID. No, you don't do that. You don't need to do that. There are other people. You know your thing best. You know specifically the amount you need to know. That's not the case in other countries. That's not the case in other countries. You just do your job good. You can have some idea, but you can't. You must refer them to the specialists on that field. And when you are the specialist of your field, you need to know your things real good, and only those things. If you want to know everything, you will forget the important things. Remember what I said, don't go too close to a tree. Don't go too close to a tree, so you miss the view of entire forest. Okay, so you don't need to know like both things. You don't need to know one thing, just one thing, details. No, there are other chapters too. You need to know all those things good, but only your trace. Let other people deal with their trace. Okay. 7-year-old child pain in scrotum 6 hours 4 months ago relieved spontaneously. If this pain relieved spontaneously this time, this patient would not come to you. That means this is an emergency case. Emergency. That means 7-year-old. Anytime a 7-year-old or 6-year old or 10-year old which comes scrotal pain, that is severe scrotal pain, immediately explore bilaterally, because if 6 hours passed, explore both scrotum, explore both testes. Okay, immediately explore both testes. Acute scrotal pain, no, chocolate bar is not the clue, guys. Chocolate bar has no association with it. Chocolate bar has no association with it. Immediate exploration under GA. Acute scrotal pain not relieved spontaneously. Not relieved spontaneously. Or acute scrotal pain with one testis high. Or acute scrotal pain with absent cremasteric reflex. Cremasteric reflex. Immediate scrotal exploration. Immediate. Okay. And if relieved spontaneously, that's torsion of testicular appendages. If relieved spontaneously, appendages or testicular hydatid of Morgagni. Hydatid of Morgagni. Simple. And absent and cremasteric reflex present. If they mention present, if they don't mention about cremasteric reflex, explore. But if they mention and it's present, then same thing. Torsion of testicular hydatid of Morgagni, just give analgesics. Just give analgesics. Newborn following her first meal presented with abdominal distension, vomiting, and infrequent passage of meconium. That means meconium is passing but infrequent. Infrequent. If meconium is passing but infrequent, that's meconium ileus. And if they give that his his brother has a recurrent respiratory tract infection, that's meconium ileus. Meconium ileus. And no passage, that is infrequent passage, no passage of meconium, and 48 hours passed already after birth, that's Hirschsprung's disease. Okay, before 48 hours, before 48 hours, let's say meconium passed but after 24 hours, that's meconium ileus. Meconium ileus. If 48 hours have passed but no meconium passed, that's Hirschsprung's disease. Hirschsprung's disease. 24-year-old man with long-term history of Crohn's disease has recurrent abdominal pain, loss of appetite. Albumin is 29, that is low. Albumin low. So, give total parental nutrition in case of perforation, in case of long-standing Crohn's with low albumin. In case of segmental resection and less than 200 centimeter bowel remaining, give TPN. And if you will have only these three scenarios in case of TPN according to class. This is nothing, just they are just asking what will be the maintenance fluid. Simple, that's our choice of fluid. 1 liter saline plus 1.5 liter of 5% dextrose. Simple as that. Fat embolism. Fat embolism, best supportive care. That means medical treatment. Just medical treatment. That is low molecular weight heparin or other things. Medical treatment according to the need. Okay, according to the need. After 7 to 10 days, if they say death, fracture, then 7 to 10 days, then shortness of breath and death, that will be pulmonary embolism. Pulmonary embolism. Okay, simple. 40-year-old patient on laparotomy operation take a depolarizing muscle relaxant. What is the name of depolarizing muscle relaxant? We know which one is the depolarizing muscle relaxant. Succinylcholine. Remember it. Remember it. These are just one-line questions that comes and get an easy mark just by remembering. No understanding needed. Just by remembering, you get this easy 1 mark. 38-year-old man bears block prelocaine, just from my note, just from my notes. Hypothermia, just see my chart of hypothermia. We have a beautiful chart of hypothermia. we have a beautiful chart of hypothermia, guys. Bacteria, virus, biopsy, bladder, bypass, claudication, clean dirty wound, colon resection, CT chart, CT timing, fluid calculation. Where is hypothermia? Okay, the chart we have. Let's say in emergency trauma, 198. So here we have the beautiful chart of hypothermia I have. See, we mentioned by 28, 29, 30. We mentioned by degree, we didn't mention by range because people have a really hard time. There is no other book in this world, no other book in this world that has mentioned like this. So we made your exam so much easy with single simple small details. You will, if you put some attention, you will understand that they will give you in other books or somewhere they will give you a range 27 to 30. Now when they will give 27 to 30 range, 30 to 32, you will get confused. What will you give if the temperature is 30? You will get confused and you will not have people to explain it you to. So we solved this problem. We made it so easy. We just specific number. We gave specific number, no range. Installation of warmed intraperitoneal fluid. 63-year-old woman with a cecal cancer is booked for an elective right hemicolectomy. She asked about the benefits of enhanced recovery program. I have told you, just remember one thing from ERAS: reduce length of hospital stay, sometimes by 100 days. Diabetic, hypertensive, history of kidney prepared. Remember which of the following score is not relevant. Just remember, we all know that these are score used in medical science, and this is not a medical science score. This is that 10% question from Tarek Zia. So sorry, man. This, so don't worry about it. No one will be able to answer it. If did, people would not get 245 highest or 260 highest. We don't know what's the highest, but from our course, 247 was highest. Okay. People with a history of MI and atrial fibrillation with admitted to ICU due to symptoms of abdominal pain, parectal bleeding, abdominal distension. He had a blood pressure contained metabolic acidosis. Which of the following best describes lactate production? Guys, lactate production in metabolic acidosis. See, anytime. How does lactate produce or lactic acidosis happens? Anytime there's a hypoxia, this let's say low oxygen, so our tissue gets low oxygen. So in presence of oxygen, mitochondria produce glucose into, and aerobic respiration happens. Aerobic respiration happens. Pyruvate, sorry guys, 1 minute. Okay, when there is less O2 in our body, our tissues, our mitochondria needs oxygen for aerobic respiration. In aerobic respiration, we get glucose and ATP. Now we don't have oxygen, but we still need ATP. Okay, how do we get ATP? We metabolize glucose. We get pyruvate. Pyruvate goes into Krebs cycle and we get ATP. You don't need all these details. Just remember now, in presence of oxygen, we get this cycle. Now, when we don't have oxygen, this pyruvate, more of this pyruvate converts into lactate. Now, this lactate production comes with an additional proton production. So we get lactate plus H plus. So in anaerobic respiration, mitochondria cannot function well and make more pyruvate into use, take more pyruvate into use. Mitochondria have oxidative stress. Mitochondria works less. So pyruvate enters Krebs cycle less, and rest of the pyruvate which does not enter mitochondria, that becomes lactate and proton, that produces lactate and proton. So we get lactic acidosis, simple as that. So produced due to tissue perfusion, reduced tissue perfusion, that's the thing. Anytime a wound develop wound crepitus and area of surgical incision, wound appears swollen and foul odor, not a good sign, not a good sign. Increasing pain and fever, most appropriate treatment, first of all debride, and you can drain place with a foul. Anytime this kind of scenario get, anytime this kind of scenario, that means it can be gas gangrene. It gas gangrene, you have to debride and give antibiotics. Given the pleurodesis fluid protein level 61 gram per liter, which of the following statement is true regarding pleural fluid and serum protein ratio? This is the normal ratio of pleural fluid and serum protein. Pleural fluid protein and serum fluid protein is less, should be less than 0.5. Remember this criteria. Remember this criteria. 100% important chart. 55-year-old patient who had previously inserted central catheter suddenly collapse. Patient is showing signs of hypotension, distended jugular vein. So hypotension, distended jugular vein, that's an obstructive shock, most probably. Obstructive shock. There is a concern of potential air embolism or other severe complication. What is the most appropriate immediate action to this scenario? Left lateral decubitus position. Memorize it. Memorize it. This is just a information they want you to memorize and they want you to remember. Okay, they wanted to remember this non-invasive. What's the non-invasive method we can take immediately? Immediately left lateral decubitus position. Place the patient in left lateral position. 55-year-old patient who recently underwent abdominal surgery presents with symptoms of dyspnea, hypotension and tachycardia for 2 days post-operation. See, hypotension and tachycardia. That means that person is having a shock. Now, abdominal surgery, after surgery, that person, which kind of shock he will have? They didn't give any BP, so they didn't give any history of blood loss, right? After surgery, he will have, so in this case, he will have septic shock. That's the most possible scenario. Okay. And then he has normal air entry in lung, decreased air entry in other lung, along with bilateral basal crackles. So decreased air entry in other lung. That means that person might have pulmonary embolism. Okay, pulmonary embolism because patient symptoms of dyspnea. Patient is having dyspnea and decreased air entry in other lung. Remember, air entry, decreased air entry on other lung. and dyspnea. That means that person might have pulmonary embolism, simple as that, with hypotension and tachycardia. So what do we give? That's the question. See, norepinephrine would be the best choice here. Now, adrenaline would not be the best choice here because it's anaphylaxis or cardiac arrest, not first line in this context, because there is no sign of anaphylaxis. It's just one one lung one lung has decreased air entry, other lung is okay. So giving, if we give adrenaline, one lung might get helped. It's not a generalized thing. Both lung is not affected. But what about other lung? That's a good lung, healthy lung, so that can get damaged. So we can't give adrenaline. Dobutamine just in cardiogenic shock. It's beta 1 selective. Beta 1 selective. We will have it in our, you will have it in our flashcards. I will add those as I update my flashcards before every exam. So this is the time you get your new flashcards. Okay. So no fast line on with fast line hypertension will come from low ejection fraction. Just forget it, don't worry. Hydrocortisone, no, not like we don't have adrenal insufficiency, right? We don't have here low sodium or something. Antihistamine, anyway. So norepinephrine would be the best choice here. Norepinephrine would be the best choice here because it will help maintain the main arterial pressure by vasoconstriction, improving organ perfusion. Here I have written down the things in a little bit of details. I will give you that thing in our flashcard. Okay. 65-year-old man with history of prostate cancer with new symptoms of back pain. So prostate cancer, anytime a prostate cancer patient comes with back pain, remember it's metastasis, bone metastasis, bone metastasis to lumbar vertebra through venous plexus, internal vertebral venous plexus, internal vertebral venous plexus, through internal vertebral venous plexus. So the best thing to do is give radiotherapy, and the metastasis type is sclerotic metastasis. Sclerotic means bone forming metastasis. Okay, see here they mentioned sclerotic metastasis. So what will you find? So anytime a prostate cancer patient comes with sclerotic metastasis, that means his PSA would be high, prostate specific, because the cancer will be flaring again. So he will have a high PSA. So this thing is patient is having elective surgery, diabetic patient. And anytime there's a poorly controlled diabetic patient, remember, in case of complication, they will give you some specific things. Orthostatic hypotension, again, wound infection, orthostatic hypotension, these things. Only these things they will give. 2-year-old boy has 2 centimeter umbilical defect reducible hernia. Mother is worried. Remember, a 2-year-old boy, if having umbilical hernia, don't worry about that at all. Watch for 5 years. Watch for 5 years. Up to 5 years, a person can have umbilical hernia. And after 5 years, if it's over 1.5 centimeter, it will regress. It will regress and it will be normal after years, normal after some years, normal after some years. So if it's over 5 years and it still persists and it's larger than 1.5, then do the operation. Which of the following is commonest site of thoracic aortic injury in case of blunt chest trauma? I have told you several times in class that descending aorta just distal to the left subclavian artery. Descending aorta just distal to the left subclavian artery. Descending aorta. Why? See, we have here BCS and here we have pulmonary trunk. From pulmonary trunk we have ductus arteriosus in our fetal life. But when lungs gets blood and the road opens, watch our fetal circulation video, this ductus arteriosus gets closed. gets closed, and it's replaced by unused artery is replaced by a ligament that is called ligamentum arteriosum. Ligamentum arteriosum. Now ligamentum arteriosum. So anytime there's a pool, this artery is aorta is mobile. It's free. It's free. So in case of a blunt trauma, let's say it goes this way and pulmonary trunk does not go this way. So tear generally occurs here, that is just distal to left subclavian artery. As we know, BCS left subclavian artery, and it's a little bit distal, so just distal to left subclavian artery we generally get the tear. A lady with a history of renal cancer presents with pain in sternum. What is the most appropriate management? Radiotherapy. Remember, radiotherapy is the most appropriate or best treatment. Or initial treatment, if they ask about initial treatment, NSAID. Remember, X-ray shows signs of joint space narrowing and osteophyte formation. Given the history of hip fixation and current symptom of pain X-ray findings, what is the most likely diagnosis? See, most of our candidates gave this answer, which is collected by our co-mentors and others, our candidates. So, secondary osteoarthritis, no. Secondary osteoarthritis takes at least 4 5 years of previous fracture, so this will not be the answer. This is a question from complication of hip fixation. Complication of hip fixation. So avascular necrosis is the most common complication. Here we have mentioned the complications. I will give you this in our flashcards. This is not in our books because I did not yeah, because I keep these things for classes. My opinions are only found in classes. Okay. So here are the complications, all the complications for hip fixation. You don't need to know all. Remember, if they give, they will give you only this, but others are nice to know. This will give you more confidence. Which of the following interventions typically encouraged under ERAS protocol? Early removal of NG tube, early mobilization, early removal of NG tube, early oral feeding, all these things. Just remember these things. Early oral feeding. Now, which of the following side effect is commonly associated with TPN? Commonly associated with TPN is hypophosphatemia. Okay, hypophosphatemia, hypomagnesemia. Remember these two. They usually give these two. Following lab results, clinical presentation, which condition is most considered uncompensated metabolic acidosis? Simple and easy and beautiful question. Uncompensated metabolic acidosis. Let us determine first from the question. In case of metabolic acidosis, what will we have? We will have bicarbonate that is lower than 22. Okay, because normal value starts from 22. So, for uncompensated, that means pH will be more than 7.45. More than, let's say 7.48 or others. Okay, uncompensated, that means carbon dioxide will be normal. Carbon dioxide will be normal, that is 6 to 8 kilopascal. Now let us check for this scenario in our options. That's how we approach our questions. See, first thing, lactate is not in our, I didn't tell you about lactate, right? So forget it, don't go for it. Serum bicarbonate 24, that is normal, so that will not be in case of metabolic acidosis. pH 7.38, guys, oh, this is acidosis, so pH would be less than 7.35, less than 7.35, less than 7.35, that means 7.2, let's say 7.31, like this. Okay, so 7.38, pH 7.38, no, it's alkalosis. Alkalosis. Serum bicarbonate 18, this makes somewhat sense, and normal PCO2, yes, that will be our first choice. But let's just check other last one. pH 7.22, yes, this is acid with a partial pressure of carbon dioxide 30 millimeter mercury. No, this is not, this is not our this is uh, this does not go with our presentation of the question. This does not go with our presentation of the question. Carbon dioxide should be normal. So D is our best choice. Okay, D is our best choice. Pulmonary embolism, what the common ECG finding? What did I tell you? Only two ECG. Pulmonary embolism and hypothermia. Hypothermia. J wave or Osborne wave? J wave, Osborne wave, or S1 Q3 T3 in case of pulmonary embolism. Q wave in lead 3. Simple as that. Given the patient's weight 50 kg, maximum amount of lidocaine with adrenaline, assuming a standard concentration of 1%, with adrenaline can be safely administered. That means they are just asking how much lidocaine with adrenaline we will use in a 50 kg patient. Let's say, what's the concentration? 1% lidocaine. So in case of lidocaine with adrenaline, the dose is 7 milligram, highest 7 milligram per kg. Our patient has 50 kg. So our highest dose for this patient would be 7 into 50. That is 350 milligram. Now, how many ml? How many ml we have to calculate that? Remember, 1% lidocaine. 1% lidocaine means we have 1 gram in 100 ml. We have 1 gram in 100 ml lidocaine. Okay, let's just write it again. We have 1 gram in 100 ml lidocaine. So 100, our dose is 350 milligram. So 1 gram is equal to 1000 milligram. 1000 milligram in 100 ml. So 1 milligram will be in 100 by 1000 ml. So 350 milligram would be 100 by 1000 into 350 ml. Let's say 0.00000, and we have 35 ml. So what's the shortcut? Shortcut is, what do you do? Weight into highest dose 7 milligram per kg by 10. Simple. That's how we get it, right? So let's break it down. So 100 by 1000 would be 10. So 1 by 10 into, how did we get 350? We 50 kg male with 7 milligram per kg, right? So what we did, we just made it like this. So weight into 7 by 10. This will be the dose of lidocaine with adrenaline. 1% lidocaine with adrenaline. Okay, so if they said 2% lidocaine, if they said 2%, that means 2000 milligram in 100 ml. So we would do it like 1 milligram would be in 100 by 2000. Simple. So we would have 1 by 20. Okay. So in case of 1% lidocaine, all we do is, if they say lidocaine plus adrenaline, simply weight into 7 by 10. 2% lidocaine with adrenaline, simply weight into 7 by 20. Simple and easy. See, life is very easy with our coaching. Of course, math too. I was very good at math when I was a young boy. Anyway, so 1% lidocaine only. Lidocaine only, no adrenaline. So weight into 3, that's the highest dose, by 10. 2% lidocaine only. Weight into 3 by 20. Divided by 20. 1% lidocaine plus adrenaline. Weight into 7 by 10. Simple and easy, guys. 2% lidocaine plus adrenaline. Weight into, sorry guys, 7 by 20. So that will be our ml, 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 ml. So what do you do? Write it down, and the pen and paper you will have in the exam hall, just write it down before. Not a problem. What is the most likely underlying cause in a prolonged QT interval in this patient? Guys, in which patient? We don't know. People just told us like this. So prolonged QT interval, we will have two scenarios. One, TPN. Remember, it's hypomagnesemia. The person is having TPN. It's hypomagnesemia. And prolonged QT interval with perioral paresthesia, carpopedal spasm, and Shopstick sign. You will have either this one or this one as presenting complaint. This will be hypocalcemia always. Postpartum hypothyroidism, currently breastfeeding. What is the appropriate propyl thiuracil? Person with heat in a precordial region, conscious, lethargic, distended neck vein. Simple as that. Obstructive shock. Anytime there's a distended neck vein, either they mention heart sound or not. Either they mention heart sound or not. Remember, in MRCS part a distended neck vein will always give an answer of obstructive shock. Always. A distended neck vein with hypotension is always obstructive shock. 22-year-old man has cervical vertebral trauma, upper limb weakness more than lower limb. This is a very simple and beautiful picture of central cord syndrome. That's what central cord syndrome, uh, that's how central cord syndrome presents. Upper extremity more weak. Distal muscle more affected than proximal muscle. Okay. Distal muscle more affected than proximal muscle. Simple as that. 9-month-old child with impalpable testes. Guys, 9-month-old child. Testes should descend by 12 months. If it did not descend at birth, by 12 months it should be descended. But if a person is 6 months or 9 months, you wait up to first birthday. That means up to 12 months. And 12 month you check the baby, and if the test is descended, okay. If not, then visualize under general anesthesia. Visualize under GA. And if you see the testis, you do the operation. You do orchidopexy. Okay. Surgical exploration under general anesthesia. Okay. And anytime there is an option of open versus laparoscopic, always choose laparoscopic. Just a general information about MRCS. Always choose laparoscopic. Always choose laparoscopic. 35-year-old child has burn on anterior abdominal wall and thigh. What is the first step? Remember, anytime there's a burn, the first step is cool the burn. Cool the burn with tap water, running tap water, and room temperature water. Remember it by your heart. 75-year-old active man has suffered a fall. He was returning from the town. X-ray revealed a displaced subcapital femoral neck fracture. Simple and easy. In case of subcapital femoral neck fracture, you will have only these two scenarios: old Young. If young, you can do internal any operation because he is young. In old, you will get two scenarios. One is active, one is inactive. Who is active plays golf. Plays golf. That means he's active. He's good. And who is inactive stays in nursing home. Works with Zimmer frame. Zimmer frame. All these things. Stays in nursing home. Works with Zimmer frame. All these things are inactive. Signs of inactive people. Inactive. So what you do? In case of inactive person, you do hemiarthroplasty always cemented. Or total hip replacement in active person always cemented. 50-year-old woman sustains a displaced distal radial fracture. This is manipulated under anesthetic and treated in cast. After 6 weeks, after 3 months, returns fracture with painful. Anytime it's painful, it's malunion. Anytime it's painful, you will have problems regarding this explanation. You will say, by in 2022 question, maybe you said it's non-union. Guys, that was a misunderstanding. But remember, this is the latest explanation, and accord always follow the last one. So latest explanation is this, that anytime there's a pain, it's malunion, because non-union will have no pain. Non-union will have no pain. Okay, and X-ray will show that fracture is not united. Not united. And you need 9 months, 6 to 9 months to establish the diagnosis. 52-year-old man presented with ruptured abdominal aortic aneurysm. He has a cystic medial necrosis. What's the most likely reason? Very simple. It's a connective tissue disorder, Marfan syndrome. Just like we told you, CT angiography shows occlusion of both SFA and popliteal arteries. Guys, see, long segment, very long segment. SFA is a very long artery. Again, popliteal artery is a very long artery. So, both SFA and popliteal arteries, both SFA and popliteal arteries are gone. So, we have only anterotibial artery functioning. Where do we take the line? Where do we take the line? So it's quite impossible. So the best thing to do is medical treatment. If this occlusion gets a little bit improved, then we can think about bypass. Angioplasty is totally impossible. This long segment. 45-year-old patient has a slow growing, firm, painless lump in front of her ear. Slow growing, firm, painless. That means it's a carcinoma. Okay, so pleomorphic adenoma would be the best option here. Skin cancer, no, it doesn't present like that. Skin cancer does not present with a lump mostly. Lipoma is soft fluctuant. Osteoma generally occurs at the angle of jaw, and osteoma does not present like a lump. Okay. Preauricular sinus, no. Which of the features of mammogram least likely? Only one thing, popcorn calcification. Only one thing I told you in my breast class, that you have to know. Remember one thing, that is popcorn calcification, that is benign. 50-year-old man has neck swelling, examination has deviated trachea. Lower border of this mass can't be felt. Only one thing that can be, that is retrosternal goiter. We all know these things cannot happen. These things are not like this that you can't feel. The muscle, nothing to explain. Carcinoma of bronchus is blurring of vision and headache, that is raised ICP. What did I tell you? In case of any carcinoma which raised ICP, give dexamethasone. Dexamethasone. 72-year-old patient diagnosed with subdural hemorrhage after head injury. Next day after evacuation, he presented by headache, nausea, vomiting, low plasma sodium. So this is the problem. Low plasma sodium, low plasma osmolarity, high urine osmolarity. So anytime after a hemorrhage, two things can happen. ADH can work more or ADHY can lose its function. Okay, why? Because posterior pituitary secretes ADH and oxytocin. So ADH can get affected due to extradural hematoma, brain gets pushed, and pituitary stuck gets damaged. So posterior pituitary gets damaged. If posterior pituitary gets damaged, ADH can work more or ADH can lose its function. And what's the function of ADH? ADH reabsorbs water from cortical collecting tubule. Cortical collecting tubule. By implanting aquaporin 2 in our collecting tubular cells, and water gets inside our body. So if this is urine and this is blood, let's say in urine we have 300 sodium, 300 water. In blood we have same 300 sodium, 300 water. Now aquaporin has increased. So ADH is pulling water from urine. ADH is more. When ADH is more, aquaporin is more. So from this 300 water, ADH takes in plus 250 water. So now we have 300 sodium but 550 water. And here we have 300 sodium and only 50 water. What did I tell you about osmolarity? Osmolarity is basically amount of sodium. So in urine, now we have a lot of sodium. Amount is same, but water has reduced drastically. So our sodium content is too much here in proportion to water. So we have a lot of sodium. So here osmolarity will be high. Osmolarity will be high. And here we have same amount of sodium but water has increased a lot. So here we have low osmolarity now. Low osmolarity. Now we have low osmolarity here. Okay. So if ADH works more, so this is sodium is okay, but water is more. So this we will call dilutional hyponatremia. Dilutional hyponatremia plus low osmolarity. And due to water is high, we will have high blood volume and of course high BP too, but with low sodium. Low sodium. And in urine, we have increased osmolarity. Okay. If ADH works less, the picture will be just opposite. Just opposite. So now here we are seeing that we have a high urine osmolarity and low plasma osmolarity. That means our ADH is working too much. Working too much. So what do? We ADH, another name of ADH is vasopressin. Did I tell you previously? Because it presses vessels. That means it increases total peripheral resistance anyway. So we give an antagonist to it. And if they said that we have a high plasma osmolarity and low urine osmolarity, we would have used vasopressin agonist. That means we need exogenous ADH to do the work. Mostly desmopressin is used.